Hi, it's me, Ingrid INFP, and this is part of my series where I talk about medical things. I was at the Heart Lung Days, which is a medical congress in Stockholm, where all of these Swedish medical specialists get together and talk. I'm going to be focusing now on COPD because that was the theme of this next part. COPD is a lung disease that is chronic, that often is progressive, meaning that it gets worse with time, and it is basically a smoker's disease. Smoking people. The smoke destroys, it gives emphysema, like big alveoli. The alveoli are the little like bags that are in your lungs. The small microscopic bags in your lungs become bigger and they can't compress the air out as hard, and also you get basically it's like the regular metaphor that they use is like normal lungs are like a balloon, it's elastic, while a lung with COPD is kind of like a plastic bag instead. It's kind of smushy because there's so much air and you can't push the air out. Like, it's not elastic in the same way. So what should we do? What is the most important when we have a person with COPD? They get inhalators, and well, first, number one, stop smoking. That's number one. And basically that is the biggest thing. Now, it's a chronic disease. So we can't expect it to be getting like good, but we can expect that we can be better with medicine. The medicine is inhalators. So that is what it is. But first, we want to find out, how do we know that a person has COPD? Well, first we check if they smoke and help them stop smoking. And then then we go to the next step, and we can buy a COPD measure, which my healthcare center has like one where I work. So I don't know exactly where it is always. But by using that, then you can tell if the person does not have COPD. So that's good. They blow in it and it says if they have COPD. That's if you don't have COPD. But if there's still a clear sign that they do, then they should do a spirometry, basically breathe in the machine called a spirometer, and they should do this quickly so that we can put in the medicines, and do an x-ray of the lungs to see how the lungs, if they're very blown up or not. If everything is kind of like weird, then you might consider asthma as the disease, or heart disease, because it gives sort of the same sorts of symptoms. Then you say, okay, you have COPD according to the spirometer. Basically, the difference between asthma and COPD on the spirometer is because it's the same thing, that you can't breathe out as fast as a regular person. The difference is that with COPD, you don't get better with corticosteroids because it's not the inflammation that is the problem. Some people with COPD have also some inflammation, but those are the people with like the worst kind of COPD. COPD in itself does not really get better with corticosteroids. there are other kinds of medicines that they use. Muscarinic, I think, receptors. Something that people with COPD have to think about is that it's actually bad for them to have a BMI under 22, because that means that they don't have the muscles to compress their lungs anymore. So BMI under 22 is actually bad for a person with COPD. So they often have to go to a dietitian or a nutritionist. Also, they need to be able to walk. So we often do a 6-minute test of them walking to see how good they walk. And something that's important is to have a planning with them and to report them in the registers. In Sweden, we have great patient registers, which is not very comparable to the rest of the world. In the US, everything is privatized, so there's not a lot of registers, except the ones that, like Kaiser Permanente has registers, and that's because of socialized medicine. Basically, we can do this, and also because Sweden is kind of it's a large country. Denmark also has registers like this, but it's a smaller country. But it's not that big that this register thing would cause chaos, basically, in a bigger country. So Sweden has like this weird thing where it's like a lot of epidemiology happens in Sweden because of that. Anyway, that was a sidetrack. Something that is important is that the patients they follow the instructions of the medication, and that the healthcare system has like checkups, follow-ups to see how things are going with the smoking, how things are going with maybe their other diseases, how like if they need an extra vaccine because they are more at risk, how things are going in rehab if they have been at a hospital because of their COPD. And sometimes you need to check if the diagnosis has gotten worse, and so you need to look at the spirometries again, or that kind of thing. Look at their BMI level. And the way that you measure different things is there's a score that COPD patients have to fill out. That's called a CAT score, C-A-T. And that measures how bad the symptoms are for the patient. It's subjective, but it's still pretty good. Then they take their blood oxygen levels, their weight, and different blood samples sometimes. In the worst of cases, usually things go well with inhalations, but in the worst of cases, you can get a lung transplantation, or it's palliative care. It's pretty bad, and often these patients develop lung cancer, and so that's not great. To know if it's not heart disease instead, it's important to check the heart and all that. Take the blood values, check with a spirometer if it actually is COPD, that kind of thing. Sometimes it's hard to know if people have a heart disease because their lung disease makes it so that they can't walk. And so then we're like, oh, well, it's just because you have a heart disease, a lung disease. And then it's like, well, you actually had a heart disease underneath all that we had missed because we thought that it was because of something else. So, what about treatment, the regular treatment, the inhalations? Important with the inhalation technique and choosing the right inhalator for the right patient. Sometimes you need to use a spacer, like a big jar kind of thing, a cylinder, because the patient can't inhalate the medicine enough without it. Better to have one inhalator that has everything in it rather than just like several different ones. Unfortunately, not very common nowadays to have a combination. So we'll see if that's the future. The most important is that the patient stop smoking, that they exercise, and that they have an okay nutrition, so that they don't like become underweight and have no muscles and such. The COPD is broken up. It used to be A, B, C, D, and that's what I learned like 2 years ago, basically, for my internship exam. But now it's just A, B, and E, basically. A means like you don't have a problem. You have very few symptoms. B means that you have a lot of symptoms, and that's according to CAT score, which is the formula that's like the self-reported symptoms from the patients. So if you have a lot of symptoms, you're B. If you have no symptoms, you're A. And now, if you have an exacerbation, which means like a terrible attack, basically, either you have, I think it's either you have 2 terrible attacks within a year, or you have one, but that one is so terrible that you have to go to the hospital for it. If you have one during that year that you have to go to the hospital for it, that means that you're in group E directly. So A, they get long-acting beta agonist or a long-acting muscarinic agonist, a LAMA or a LABA or a LAMA. Okay. Then if you have a lot of symptoms, then you have both LAMA plus LABA. And you take these every day. And if you're an E, then you can check if you maybe you're one of those people who has inflammation as well. So it kind of looks like asthma. So maybe you need to have the corticosteroids on top of the LAMA plus LABA. So that is the treatment. There are tons of inhalators. I don't know the names. It is kind of confusing, basically. Between the inhalators and the lung transplantations, I forgot about this because this came in the next lecture. There is the CPAP machine that brings like a pressure, an air with pressure towards the face. This is something that we did also during COVID a lot. A lot of people with COVID were overweight, and so getting the air into the lungs was difficult unless you had like this CPAP mask. And nowadays people can take a CPAP machine home, and even a BPAP machine, which is an even better version, basically. That is if they have been to the hospital and they still have problems, even if they got like oxygen in the hospital and all sorts of things, and they have needed a CPAP machine or ventilator machine at the hospital. It's non-invasive as opposed to invasive, meaning being intubated, which isn't fun. It's not fun with CPAP either, but at least you're not getting intubated. You can't be conscious. Like, intubation is usually when people are unconscious or put to sleep. While CPAP, you can still like be awake and you can still do your things. And so that's why it's preferred. So yeah, that is that. In the future, they're thinking of like maybe like putting little ventils inside the lungs. Pretty interesting. They're trying these things out. At the moment, there are only a few patients in Sweden that are being tested for this. We'll see how that goes. So yeah, that was all I had to say about COPD. There used to be a medicine called theophylline, which was like before we knew like how to do ventilators for COPD. That is not used anymore. It used to be used like, 30 years ago or something, 50 years ago. And a lot of my colleagues have used theophylline quite a lot when they were younger. But the problem is that it's not very good medicine, and also it gives a lot of interactions with other medication. So it's not a very practical medicine. So yeah, that was that. And the next one is going to be about constant, basically the digitalization with like control. So like in 1984, the surveillance, is it good or is it bad in medicine? So that's something to look forward to. So have a great day, everybody. Bye.